Bismillah, welcome back to our nephrology lectures about conventional hemodialysis. This is lecture number 10, and in this lecture we will continue discussing chapter 8, complications during hemodialysis. In this lecture we will discuss, and this is the last lecture regarding chapter 8. We discussed chapter 8 before in 2 lectures, and this is the third and last part. We will discuss the different complications, the different other complications that can occur during hemodialysis. In the description of this video in YouTube, below the video, we will find some important links. The first link is a link to this same lecture, but in Arabic language, for those who like to watch the lecture in Arabic. You'll find also a link to the playlist of video lectures about this book. You will find the link for the English playlist and Arabic playlist. You'll find link to download this book for free. You'll find link to download the PDF of this lecture for free if you like to use it. You will find a link for my website NephroTube, nephrotube.com, where you will find more lectures about nephrology than hemodialysis lectures. And finally, you will find a link to NephroTube social media accounts, the WhatsApp group, the Telegram channel, the Facebook group. You can join us to be always updated by the activities of NephroTube. And finally, it's better to subscribe to our channel and to make the notifications on from our channel, so you will be notified once we upload new lectures. Let's start by headache. Is headache a common symptom during hemodialysis? The answer is yes. Headache may present in about 28% to 30% of patients during dialysis. What are the causes of headache and how to approach each cause? First of all, hypotension may be the cause of headache, and we discussed before how to treat and correct intradialytic hypotension. That's why in each patient who complains from headache, that you have to measure blood pressure, because also accelerated and severe hypertension during hemodialysis may be the cause of headache, and we discussed before in details how to deal with intradialytic hypertension. Next, one of the common causes, by the way, for intradialytic headache in patients with hemodialysis is the caffeine withdrawal symptoms. As caffeine can be dialyzed and the blood caffeine concentration is sharply lowered during dialysis, this may be the cause of headache in some of the patients. And this can be treated by just a cup of coffee, or can be avoided also by a strong cup of coffee before the hemodialysis session. Hypoglycemia also may be a cause of headache during dialysis. That's why if you have a patient with a headache on hemodialysis, you have to assess the blood pressure of the patient to exclude hypotension, hypertension, and you have to check the patient's random blood sugar. The next may be the next may be hyponatremia or hypernatremia, may be the cause of headache. That's why you may check serum sodium in these patients, and also magnesium deficiency may be a cause of the headache. You can check the magnesium serum level in the patient, especially if the headache is recurrent in this patient, and take care, as we mentioned before, that there must be a caution to be taken while administering magnesium supplements to dialysis patients, because it may be toxic. Other causes of headache may if the patient already has a history of migraine, you can re-evaluate the migraine therapy, the drug dosing, and dose modifications. Disequilibrium syndrome may be the cause of headache, but as we mentioned before, it will be a diagnosis of exclusion. Also, intracerebral hemorrhage or any other neurological cause may be the cause of headache. But in this case, the headache will be severe headache or atypical headache. And here the brain imaging will diagnose the case. Another and last cause of intradialytic headache, and it is also a cause of exclusion or a diagnosis of exclusion, is that there may be dialysis associated changes in nitric oxide that may cause severe bifrontal or temporal headache that starts immediately after the initiation of dialysis and becomes more worse over the duration of treatment and resolves within 72 hours. If this is the case, this can be avoided, and for sure this will be recurrent headache. If this is the case, you have to, or the management can be in the form of having a shortened, more frequent hemodialysis session. And this may be effective in alleviating this headache. The next symptom that can be manifested during hemodialysis, and it can be a cause of multiple complications during hemodialysis, is nausea and vomiting. Nausea and vomiting is very common. It can occur in 9.8% to 18.2% of dialysis treatments. Regarding the causes, first of all, maybe hypotension. That's why all patients with vomiting and nausea, you have to check the vital signs of blood pressure. Disequilibrium syndrome, and this will be a diagnosis of exclusion. Type A and type B dialyzer reactions, and we will talk about type A and type B dialyzer reactions and how to suspect in this lecture after a while. The gastroparesis. Some patients or many patients on hemodialysis have gastroparesis, and this is observed more in diabetic patients. Also, hemodialysis may aggravate gastric acid secretion in some patients, which may cause nausea and vomiting. And finally, if there is high dialysate sodium or calcium concentration due to contamination of the water coming from the water unit or incorrect formulation and proportionation by the hemodialysis machine. But if there is high sodium or calcium dialysate solution secondary to inadequate water purification by the water treatment unit, you will find nausea and vomiting not only in one patient, but in all the patients of the hemodialysis unit. Because this water with incorrect contaminations by sodium and calcium will be distributed to all hemodialysis machines, and it will reach all the patients. While if the problem is in the proportionation by the hemodialysis machine itself, you will find the symptom of nausea and vomiting only in the patient who is on the hemodialysis machine with the problem. What is the management of nausea and vomiting? First, if there is hypotension, treat it, or if there is another cause as disequilibrium, treat it. Second point, you can use antiemetics for reasons other than hypotension, because with hypotension, just you treated the hypotension itself, the vomiting will be resolved. Regarding prevention of nausea and vomiting, first of all, prevent the occurrence of intradialytic hypotension, as we mentioned in the previous lectures. And in patients who are suspected to have gastric acid secretion, excessive gastric acid secretion, you can try H2 blockers and PPIs, and you can use metoclopramide if the patient is still asymptomatic, especially in patients where gastroparesis is suspected. Regarding management of other causes as type A and type B dialyzer reaction, we will talk later about this. If there is contamination due to the water unit poor quality, You have to check the quality of your water unit to exclude that it is the cause of nausea and vomiting. But as I mentioned, this will occur in more than one patient in your hemodialysis unit. The next point to discuss is dialyzer reactions. Before going different types of dialyzer reactions, we have two types. I want to mention that historically it was believed that dialyzer reaction was common only with newly used dialyzers than reused dialyzers, and it was previously called the first use syndrome, as it was commonly only with newly used dialyzers. However, similar reactions occurred with reused dialyzer too. That's why the term first use syndrome is obsolete nowadays, and it is called dialyzer reactions, and it can occur with first use newly dialyzers or even reused dialyzers. We have two types of dialyzer reactions. Type A, which is the anaphylactic severe type, and type B, which is the non-specific mild type. Regarding incidence, anaphylactic type A type occurs in about 5 of every 100,000 dialysis sessions, while type B is more common, as it can occur from 3 to 5 dialysis sessions for every 100 dialysis sessions. Regarding onset, type B usually occurs after 20 to 40 minutes after starting dialysis, by the onset of type A is more common to be early during the initial minutes of dialysis. However, sometimes type A anaphylactic type can occur at a delayed onset for more than or equal 30 minutes. Regarding presentation, type B presents with chest pain, maybe back pain. That's why to diagnose type B, it will be a diagnosis of exclusion after excluding all other causes of chest pain, as I will mention later. You will diagnose type B after you analyze chest pain. In type A, actually, it is a form of anaphylaxis. It will be very clear to be diagnosed. Regarding mild type, you will find facial flushing, urticaria, itching, watery eyes, sneezing, cough, maybe diarrhea. In severe case, this is a severe anaphylaxis with anxiety, burning sensation at the access site, entire body, chest tightness, angioedema, laryngeal edema, respiratory failure, and maybe cardiac arrest and death. Okay, what are the causes of type A and type B, and how to manage and prevent them? Let's talk about the cause at first. Regarding type B, its pathogenesis is unclear. However, it is supposed that there may be activation of the complement by the dialyzer, and this may be the possible mechanism that induces this reaction. Regarding type A, a lot of causes are available. At first, it was due to the use of cellulose membranes that is not commonly to be used now. It may be secondary to the ethylene oxide sterilization. It may be the cause of the anaphylactoid A reaction. The use of AN69 membranes in patients who are taking ACE inhibitors. They found that ACE inhibitors amplify the bradykinin overproduction and activation in patients taking AN69 membranes, in patients who are dialyzed by AN69 membranes. They found that these membranes amplify the bradykinin system, and the ACE inhibitors do the same. That's why the release of high amount of bradykinin may be the cause of this. It is not known actually to what extent ACE inhibitors associated with reactions with other polyacrylonitrile membranes. AN69 membrane is one of the PAM membranes. It is not clear if S inhibitors can induce the same with other PAM membranes or other non-PAM based membranes. Other causes of type A anaphylactic reaction may be anaphylaxis secondary to reaction to heparin. In these cases, for sure, we will have to try heparin-free dialysis. I will talk about this later in management. Can I use low molecular weight heparin instead of unfractionated heparin? In this case, the answer is no. Low molecular weight heparin may cross-react with unfractionated heparin, and it is not a safe substitute. The next cause of the type A reaction that the use of high flux dialyzers may increase the risk of bacterial contamination transmission from the dialysate. That's why it is important to use ultra pure dialysate in these cases, as we mentioned before, as high flux membranes can be the cause to the bacterial and endotoxin movement from the dialysate to the patient. The next is bacterial contamination of reused dialyzers, especially if there is inadequate disinfection to these dialyzers. And finally, if the patient is already having eosinophilia, so patients with whatever the cause, patients with mild to moderate eosinophilia with dialysis are prone to eosinophilic degranulation, which will cause this severe reactive type. Okay, what is the management of these cases? Regarding management, in type B, if the chest pain is confirmed to be due to type B reaction, as we will talk later about chest pain, how to diagnose and manage, all what you need to do is to give supportive treatment, nasal oxygen therapy, and you can continue hemodialysis. But in type A, detecting the cause may be very difficult. In severe cases, this is fatal reaction. You have to stop dialysis, clamp bloodlines, and don't return the blood to the patient. And this is the third complication where we don't return extracorporeal blood to the patient. We did this before in air embolism and in hemolysis. Then you have to give the patient antihistaminics, steroids, epinephrine, and maybe cardiopulmonary resuscitation. In milder cases, you have also to stop dialysis, and you can give only antihistaminics and oxygen. Regarding outcome, type B is less severe than type A, and it usually resolves within half an hour to an hour, but type A could be fatal. Regarding prevention, in type B, you can change the type of the membrane, or they found that reusing dialyzers decreases the activation of the complement in type B, and it can be tried. But actually, as we mentioned before, reusing the dialyzers is not that common. Regarding type A, how to prevent? First of all, it's better to avoid ethylene oxide sterilization in patients with type A anaphylactic reaction. Use other methods that we mentioned before in the dialyzer lecture. Rinse the dialyzers and the blood tubing, and don't forget to rinse the branches, as we mentioned before, to eliminate ethylene oxide. If the patient is using AN69, you have to change the use of ACE inhibitors. Example, you can use ARBs. Change the membrane type and try to use free heparin dialysis or citrate anticoagulation. But as we mentioned before, that citrate anticoagulation is not commonly to be used in intermittent hemodialysis. And don't forget that we cannot use low molecular weight heparin instead of unfractionated heparin. Our next and very important point is chest pain. How to deal with the chest pain on hemodialysis. Before going through the practical approach, how to deal with chest pain, let's start to mention what are the causes of chest pain during hemodialysis session. First is angina due to obstructive coronary artery disease. There is obstruction of the coronary artery, but in hemodialysis patients, there may be angina without any obstruction due to the following reasons. First, it is very common in our patients to have hypertrophic cardiomyopathy with inadequate blood perfusion, and this may cause angina-like symptoms as the blood is not adequate to supply all this cardiac muscle due to the hypertrophic cardiomyopathy. The second, that our patients are at risk to develop high cardiac output due to, for example, anemia or high flow arteriovenous fistula, and the combination of this high cardiac output with the physiological stress of the hemodialysis session itself may aggravate angina-like symptoms. Other causes that may cause chest pain on hemodialysis are hemolysis, air embolism, and dialyzer reaction. So how to approach these different causes and how to diagnose what is the cause of the chest pain during hemodialysis, let's go through the clinical stepwise approach. First, step 1, there are immediate measures that you have to do when the patient on hemodialysis complains of chest pain. Do the following: stop ultrafiltration and decrease the blood flow rate. Put the patient in a recumbent position. Give oxygen and start to record the blood pressure, heart rate, and other vital signs. Then exclude serious cases as air embolism, and this will be easy to exclude. For example, you will find air foam in the extracorporeal line. Exclude hemolysis. We'll find a port wine appearance of the blood, and also in the investigations that we will order now, we can find the hyperkalemia, a sudden decrease in hematocrit, and you have to exclude coronary disease. You have to do ECG, you have to do laboratory tests as electrolytes, especially potassium, troponin levels, and CBC to exclude anemia. If you excluded all these causes, then a diagnosis of dialyzer reaction type B may be the cause, as we mentioned before. If there is no air embolism, no hemolysis, no coronary artery disease, okay, and the cardiac evaluation of the patient is good, no anemia, then the cause is usually dialyzer type B reaction. I wrote this in my book as step 3. This is step 1. I will mention now step 2. I mentioned in my book in page 109 at the end of this page that dialyzer reaction will be diagnosed of exclusion. So if there is coronary disease, what will be the next step? So step 2 is the step if there is evidence of cardiac disease, that the chest pain is of cardiac origin as approved by ECG and troponin level. The way of management differs according if there is hypotension with the chest pain or it is chest pain without hypotension. If there is chest pain and hypotension, you have to manage hypotension first. If both hypotension and chest pain resolve it, then you can continue dialysis. You can resume ultrafiltration, but when the patient becomes stable with no chest pain, and then send the patient for cardiac evaluation after the dialysis session. If the pain is persistent with persistent hypotension with the evidence of cardiac ischemia, dialysis should be discontinued. Administer aspirin, but it's better to avoid nitrate in these cases, nitrates, because we said that the patient is still hypotensive and nitrates will cause more hypotension. transfer the patient to the hospital by ambulance and start doing cardiac evaluation. The chest pain without hypotension, then you can do the same lines as here, but in this time you can give nitrates because we supposed that the patient is not hypotensive. So discontinue dialysis, administer aspirin and nitrates, transfer the patient to the hospital by ambulance, and do cardiac evaluation. The next point to discuss is dyspnea. What if the patient on hemodialysis complains of dyspnea? First of all, what are the causes of dyspnea? Then, what will be the approach for patient with dyspnea? The causes may be first isotonic saline. We typically give the patient at the beginning of hemodialysis session some isotonic saline that were used for the priming. So this volume, even a small dose, may cause dyspnea. The next point may be angina, severe hypertension, pericardial effusion, maybe pulmonary embolism, bacterial infection, especially if the patient is dialyzing from catheter, hemolysis, air embolism, and allergy for heparin. So the steps of management mainly depends on the exclusion of all of these causes. So if patient had dyspnea on hemodialysis, first you have to supply oxygen if there is evidence of hypoxia, and then try to find and treat the cause. For example, if the patient has chest pain with the dyspnea, you have to manage, as mentioned before regarding chest pain. If there is severe hypertension and this is the cause, the patient may need more ultrafiltration or treat the hypertension. As we mentioned before, in the interdialytic hypertension, you have to do chest X-ray and cardiac evaluation to exclude pericardial effusion. If there is a suspicion of pulmonary embolism, you have to do pulmonary angiography. If the patient had central venous catheter and there is possibility of infection, you have to check infection markers and CPC. Air embolism can be excluded easily, while the patient on hemodialysis also have to exclude hemolysis, as we mentioned before. And finally, if the dyspnea is due to allergy to heparin, it will be diagnosed of exclusion after excluding all other causes. Regarding dialysis continuation, if the patient has dyspnea, if the patient's vital signs are unstable with the dyspnea, and there is persistent hypoxia, it's better to stop dialysis and transfer the patient to hospital by ambulance, but you can continue dialysis if the patient is stable and there is no evidence of hypoxia and the cause of dyspnea is clear and can be resolved. The next point for discussion is cardiac arrhythmia. First of all, what are the risk factors of cardiac arrhythmia in hemodialysis patients? First, our patients on hemodialysis are prone to have coronary artery disease and left ventricular hypertrophy, and these are the primary causes of cardiac arrhythmias for patients in hemodialysis. And for sure, acute cardiac arrhythmia during dialysis is a common cause of sudden cardiac death in hemodialysis patients. Arrhythmia can be precipitated by different factors related to dialysis itself. First, dialysate-related factors. Arrhythmia is common with the use of low potassium dialysate. Also, it is common with the use of low calcium dialysate, especially if the patient has high serum calcium level, because this will precipitate a severe hypocalcemia in the patient. Also, arrhythmia is very common in long intradialytic periods, because in long intradialytic periods, for example, the patient is dialyzing on Saturday, Monday, and Wednesday. So the long intradialytic period is between Wednesday and the next Saturday. In this period, there is a high risk of volume disturbance or electrolyte disorders that may precipitate arrhythmia in the first day of the week hemodialysis session. Also, interdialytic hypotension may precipitate arrhythmia and anemia. That's why we have to exclude all these causes in patients with arrhythmia on hemodialysis. What is the management of arrhythmia? If the patient caught arrhythmia, stop dialysis. Blood can be returned to the patient, but carefully and slowly. You have to make urgent cardioversion in unstable patients' rhythm, airway management and cardiac monitoring, administration of antiarrhythmic drugs, and maybe the drug of choice in these cases is procainamide and other class 1 antiarrhythmic drugs. But take care as these drugs may induce QT prolongation and torsades de points in hemodialysis patients, and finally, for sure, cardiac consultation. The next and coming point for discussion is syncope. What are the causes that I have to exclude in all patients with syncope? First, severe hypotension. That's why any patient with syncope during hemodialysis, you have to check blood pressure, check the pulse of the patient to exclude arrhythmia, order ECG and troponins to exclude myocardial infarction, and you may order also brain imaging to exclude stroke. That's why in the management of syncope, first you have to stop dialysis, then elevate the patient's leg, give oxygen, record blood pressure and vital signs, administer intravenous isotonic fluid if the patient is hypotensive, order ECG, order lab test for electrolyte, troponin, complete blood count, and refer for syncope evaluation including CT brain. The final and last point, then I will give you an advice before I finalize the lecture. The final point is itching pruritus. I'm talking here about itching on the dialysis session itself, during the dialysis session itself. I'm not talking about itching outside the hemodialysis session, because it is very common for our patients to have itching or pruritus outside the hemodialysis session, secondary to what is called CKD-MPD, which is the abbreviation for chronic kidney disease associated mineral bone disorders, but this is out of the scope of the book. Maybe I can talk about it in a new book about chronic kidney disease, but I discussed it in details in my lectures about chronic kidney disease on NephroTube channel. But if the itching is only during hemodialysis session, especially if it is associated with allergic symptoms, so it will be due to heparin, dialyzer reaction, or blood circuit components reaction, especially ethylene oxide. So you have to try heparin-free dialysis, exchange the dialyzer, or do a good rinsing and good priming for your line to eliminate ethylene oxide. So after finishing these lectures about the complications during hemodialysis, my advice that you have to prepare a checklist. You can extract the data from the book NephroTube Synopsis of Conventional Hemodialysis, and from these lectures you have to prepare your checklist for each symptom that the patient can present during hemodialysis to be ready in your hemodialysis unit. For example, you have to put in mind your checklist, what I have to do when the patient has syncope, what I have to do when the patient has convulsions, what I have to do when the patient complains of chest pain. Okay, this is the key to master your hemodialysis shift. Because if the patient has disequilibrium syndrome, the patient will not say to you, I have disequilibrium syndrome, but the patient will present with headache, with nausea, vomiting, with convulsions. So this is the key, the symptoms. And this what I did in my book. I tried to discuss complications of hemodialysis in the form of diseases and in the form of symptoms. I covered almost all the symptoms. You will find that I covered nausea, vomiting, I covered the headache, I covered chest pain, I covered dyspnea, I covered convulsions, I covered syncope, I covered pruritus, I covered hypotension, I covered hypertension. So prepare the checklist from what you read in my book, or even if you read it from another book, or you can also extract the data from this lecture. Thank you for watching this lecture, and see you in the next lecture, inshallah.